Welcome everybody, Dr. Sherry Berger here on behalf of VetVine. Honored to be joined today by two esteemed and distinguished veterinary colleagues who are both very passionate about helping our companion animals live their best pain-free lives. We're here today to talk about an all too common problem that affects both dogs and cats, and that is arthritis. Specifically, we're talking about osteoarthritis, or OA, and a condition that we all know can be very debilitating depending on the severity. And we also know that this is a condition that can be progressive. As such, it can really impact the quality of life of our animals. And not only the quality of their lives, but also it impacts our relationships with our animals. Whether we're accustomed to going on a leisurely walk around the block with our dog, or whether it's engaging in more strenuous activities like running, hiking, or even playing on the beach. For some of us, we engage in competitive activities with our animals, and so our animals' inability to interact with us and to be active in that way impacts the relationships that we have with them. And so this segment really serves as a prelude to our Arthritis Summit, this exciting program that we're hosting on the topic of arthritis in dogs and cats. And so at this point, I'm pleased to introduce our two guests today, Dr. Marie Bartling and Dr. Sam Franklin. Dr. Bartling is a friend and colleague and a co-chair for coordinating and developing this program on arthritis. And she's joining us today from Castle Rock, Colorado. And Dr. Sam Franklin is a surgeon who's joining us from Kansas City, Kansas. So with that, Dr. Bartling, Dr. Franklin, welcome. Marie, I'm going to turn it over to you.
Thank you, Sherry. It's a great pleasure to be here. I am a veterinarian in Castle Rock, Colorado, and my practice is focused on helping animals to live their best physical life. So it means that we work on pain management, flexibility, and strength. And I see an awful lot of dogs with arthritis. So this is near and dear to my heart. I am super excited and a big fan of Dr. Sam Franklin. He joins us as a surgeon with his own practice and is among the thought leaders and one of the people I know who's put most of their personal time into research and treating animals with arthritis, traditionally with orthopedic surgery and also non-invasive surgery, arthroscopy and regenerative medicine. Sam, I'm so glad to have you here. If you want to tell us a little bit about you and your practice and the kinds of things you like to do with your dogs, we're glad to have you.
Well, thank you very much. I'm flattered that you asked me to be a part of this. I'm excited to be a part of it. It's a great program and a great number of speakers who you guys are going to hear from over the coming portion of the summit. So I currently am practicing in the Kansas City area. So we've recently opened our practice, Kansas City Canine Orthopedics. And we're going to be focused basically exclusively on orthopedics and sports medicine, with our goals being to optimize mobility and quality of life for any number of dogs. And that ranges from dogs who are just seeking pet level of function and being able to get out and take a more comfortable walk, to competitive athletes who have high drive and then also high expectations from their owners in terms of their ability to perform. And it's fun treating all those dogs of different levels, breeds, and with different problems. For myself, so I moved here relatively recently from Colorado, but typically I usually have hounds and I like running with my hounds. So most recently, of course, that was in Colorado, and it'd be miles through the Front Range and the mountains in Colorado. And so for me personally, I understand what it means to have a pet who can't actually do what you want to do in terms of activity level. So it's not as much fun for either the dog or the owner. So our goals, of course, are going to get both the dogs and people back to doing what they want to do.
Wonderful. Excellent.
Yep.
So I think maybe what we start with is really just helping us all have a big picture understanding of what arthritis really is. I think most of us kind of think of arthritis as a disease process that is going to affect us all at some point, and that there really is not a way to manage it well or cure it, that it's going to at some point affect the mobility of all of us. Sam, would you want to talk to us? I know you have some really extensive study in even at the molecular level of the process of arthritis. And so we have pet parents and veterinarians here, and it's okay to talk about it in whatever depth you're comfortable with. Tell us how you see arthritis as a disease.
Yeah, so that's a fantastic question. And there's a couple different things that I think are helpful for people, both veterinarians and pet owners, to understand. And one of the first is something that I certainly am not the one to have phrased things this way, but it's absolutely accurate. And that is, we need to think about joints as an organ. There are multiple different tissues within a joint that all need to work together in order to function optimally. And when any one of those different tissues is affected or abnormal, it affects the joint as a whole. So we can't consider just one part of the joint in exclusion of the other. And then the second really big key concept is that when it comes to orthopedics or the joint and care for the joint, we really have two areas we always have to consider. And that is the biological side of things as well as the mechanical side of things. And osteoarthritis can be initiated by either of those two or a combination thereof. So you can have a mechanical insult that damages one of the tissues, which then results in a change in the biology of the joint that progresses to deterioration of the joint. And then you could conversely have a scenario in which the biology is abnormal, and as it changes and the joint deteriorates, then you have more mechanical problems as a result of that. And so whether we're talking about the pet owner or the veterinarian, anytime we've got a patient who has osteoarthritis, we should really be considering and thinking about what are the underlying mechanics at play and how do I address the mechanics, but then also what about the biology and how do I address and optimize the biology? Because both components are basically relevant in every case to different degrees, but both areas are relevant in all cases of osteoarthritis.
So in real life, an example of a mechanical insult, for example, so we're talking about like an injury where a dog maybe is chasing a ball and hurts himself, right? A lot of times people use the example of an ACL injury. That's kind of in my experience, a mixed bag, right? It's an example of both chemistry and physics that create damage in the joint.
So cruciate ligament disease is certainly highly complex and we don't fully understand it, but we can use it as an example to talk about both the biology as well as the mechanics. And so as an example, we know, thanks to a number of very good studies done by a number of people, including Dr. Peter Muir and his team out of the University of Wisconsin, we know that in the majority of dogs, the synovitis or inflammation of the joint precedes the mechanical dysfunction of the joint in the majority of dogs. But as this progresses, we can have deterioration of the ligament, which can then ultimately rupture. And oftentimes pet owners recognize this as being an acute or instantaneous rupture, and they think that it's a true injury when really the degenerative process has preceded it. But yet it does still culminate or can culminate in rupture of the ligament, which results in the mechanical instability, which further contributes to deterioration of the joint and other tissues such as the cartilage. And so in those situations, we talk about addressing the mechanics of the unstable knee, but it is absolutely relevant for us to be thinking about, particularly as a profession, what is the underlying biology that leads to the synovitis and the precipitation of the disease process in the first place. And that's a question that for cruciate ligament disease, we don't have kind of the ultimate answer for that just yet. But again, it's a good example. Another good example and scenario that is common in a conversation that I have commonly with owners is owners have the common perception that dogs get hip osteoarthritis and that is something that occurs in older dogs. And that is a oversimplification that's not quite accurate. So the most common cause of hip osteoarthritis in dogs is hip dysplasia. And hip dysplasia is a developmental disease that occurs in dogs as they're growing. So when dogs are 8, 9, 10, 11, 12 months of age. And the osteoarthritis is secondary to the hip dysplasia and the hip laxity that is part of hip dysplasia. And so the osteoarthritis is secondary to mechanical abnormality of the joint. And so a good number of dogs have manifestation of hip osteoarthritis even before 1 year of age. So we see it in young individuals. And it's not as simple as saying arthritis is just something that occurs over time. It's not necessarily a disease of older individuals. And so the way we should think about patients with osteoarthritis are what are the underlying mechanical explanations or contributors? What are the underlying biological contributors? And how can I address each of those two areas to maximize the outcomes for the given individual?
I think that's really well said when we're thinking about this as veterinarians, specifically when it comes to treatment path and our recommendations. As you're talking about this, Sam, something is occurring to me that I haven't really put into full thought before. And that is when I'm thinking about locations of arthritis, if we talk about dysplasia and ACL disease and that, what percentage of young dog disease do you think you see causing osteoarthritis versus old age? I think we typically think about it as you said, as an old age disease. But as I'm kind of checking off risk factors in my head, I guess the direct question is, how many patients do you see that maybe have dysplasia or parts of their body that don't fit together really well, some physical reason that they have arthritis, as opposed to what we think of as old age and wear and tear?
Yeah, that's a great question. We, as a profession, and then also owners, often think about osteoarthritis as being primary. So we talk about primary osteoarthritis and secondary osteoarthritis. Secondary osteoarthritis just means that there's some other initiating factor. The vast majority of cases of osteoarthritis in dogs are secondary. There's some other predisposing explanation or factor. So osteoarthritis of the hips is most commonly a secondary osteoarthritis, with the primary explanation being that the dog had hip dysplasia. And every dog who has hip dysplasia when they are growing, finishing growing. So those dogs have had the underlying problems since they were young. The same is true for the elbow. So the vast majority of dogs who have elbow osteoarthritis, even though some of them are not recognized till older in life, is secondary to elbow dysplasia, or one of the different manifestations of elbow dysplasia. And I say that just because the term elbow dysplasia is very broad and not specific. But again, the different forms of elbow dysplasia occur in growing dogs. And so the underlying explanation for why these dogs develop elbow osteoarthritis is the elbow dysplasia that they had while they were growing, as they were young. The stifle or the knee is a little bit different, just in that the most common explanation for stifle osteoarthritis is cranial cruciate ligament disease. And cranial cruciate ligament disease can manifest anywhere from several months of age up to many years of age, but the average is middle age, 5-6 years old, just as an average. Shoulders is a little bit more challenging and difficult. It's not that straightforward. And there's at least one good study by Dr. Smith, Dr. Runge and company at the University of Pennsylvania, where they identified dogs at the end of life who had cartilage wear, substantial cartilage wear and osteoarthritis. And there was not a recognition during the course of their life as to an underlying predisposition in those dogs. So shoulder is a little bit more complex or less well understood. And then some of the other different explanations, again, just to provide contrast, are you could have individuals that had injuries to the joints, where they get infections of the joint that lead to an infective arthritis rather than an osteoarthritis. But again, we're getting back to owners and veterinarians, in my humble opinion, should be thinking about what things they can do to evaluate dogs earlier in life, rather than assuming that these dogs are just going to develop osteoarthritis later in life. Because there are some things that can be done starting earlier in life that could be beneficial, rather than waiting until after the dog manifests with end-stage osteoarthritis.
Yeah, I love it. Let me see if I can paraphrase what you said, because I think what I heard is, we should be looking as veterinarians for arthritis in dogs that are fairly young and pretty athletic. It can be pretty subtle to see signs of pain in these young dogs, right? So what can we be doing as veterinarians looking at dogs that are 6 months to maybe 5 or 6 years old that is more proactive in being able to find and intervene in their process of arthritis?
Yeah, so that's a great question. And as I answer it, I will point out the areas where my response may be not necessarily representative of all veterinarians' opinion. But to start, in my opinion, the easiest is to talk about the hips, because I think that there is very good evidence that pen hip radiography, distraction radiography, which provides a quantification of the tightness or looseness of a dog's hips, is a far more accurate predictor of whether or not the dog will potentially develop osteoarthritis of the hips later in life than is a lot of the standard radiography views that most veterinarians typically make. And so it's my humble opinion that I think that we would serve our clients and our patients well if we became certified in pen hip radiography, which is not difficult to do in my humble opinion, and then started performing and offering pen hip radiography more frequently and in younger dogs. And what could come of that are the following. So if, for example, an individual dog is identified, let's say 6 months of age, and pen hip radiography, it can actually be done as early as 16 weeks of age. You can obtain valid results starting at a very young age. But if one begins screening dogs, and let's say 6 months of age, you identify a Labrador Retriever who is at moderate risk for developing hip osteoarthritis in the future because their hip laxity is in the moderate range for the breed, then that opens up a couple different options. From a surgical standpoint, the statements I'm about to make are debatable, and there are some surgeons who would disagree with me. But there are some dogs who would be candidates for a double pelvic osteotomy that could be performed and that could be beneficial in either preventing or mitigating progression of osteoarthritis. Some surgeons are proponents of pelvic osteotomy in the right patients. I'm one of those surgeons. Some surgeons are not. What I want to do is move on to the other point, though, that I think is well substantiated, and that is Gail Smith's group and others did some excellent studies in dogs looking at diet and caloric restriction and the manifestation on hip osteoarthritis. And what they found was the dogs who had some calorie restriction, and that doesn't mean that they were starved. It means that they were kept at a very moderate and optimal body weight, had a later onset of manifestation of osteoarthritis, a lower prevalence of osteoarthritis, fewer clinical signs, and the dogs lived longer. So if we screened dogs and found that 6-month-old Labrador, at the very least, we could take that to the owner and say, hey, your dog's at real risk of developing hip osteoarthritis, and you can do something about that. And one of the things that you can do about that is you can begin adjusting your dog's diet and caloric intake from here forward to decrease the probability that your dog manifests with clinical signs attributable to that osteoarthritis. And I think that that's something that would benefit quite a few dogs and is well substantiated and well supported by data. So that's just one example where I think that we could begin to consider screening dogs sooner. It takes more work, but I think that there is the opportunity there for veterinarians to do it. It would be good for their practice. It's good for the clients, and it's good for the dogs, in my humble opinion.
I think that's awesome. I think in general, what I heard is there are sometimes early preventative surgeries that we can do to help them with their physics. And this would be a really good time for me to share maybe an example of that. So I have a patient, he's a golden retriever named Henry. So Henry got his pen hips x-rays done at 16 weeks. And so he actually got to have a JPS surgery, which would be interesting to talk about. He also started his joint supplements early. And of course, yes, he's a super fit and thin golden retriever. What was really special about how his owner took care of him is he also started early rehab. So it means that we started working on his balance and his symmetry. And so as he is growing into his gangly body and his, unfortunately, loose hips, he really struggled. He had a hard time going upstairs. He had a hard time jumping on the bed, and he was afraid of everything because he really felt like everything was going to hurt him. And so this manifested in a really big way for Henry. So say that we had not done his pen hip x-rays quite so early, but maybe we found him as a 2-year-old dog with hip dysplasia. What could we do at that point for a dog that has this kind of developmental cause of arthritis?
So if we're talking specifically about hips, if the patient is 2 years old and has hip osteoarthritis, we're limited in terms of what our options are at that point, at least in broad choices. And what I mean by that is if you have a patient with hip osteoarthritis, they're 2 years old or older, and quite frankly, typically a year or even younger than that, we've missed our window of opportunity for doing a JPS or a pelvic osteotomy, which means the choices then are non-surgical management, which is a very large category, right? And that's a lot of what the discussions in the rest of the summit are going to cover. But there's non-surgical management, there is femoral head and neck excision as a surgical option, and there's total hip replacement. And all of those options are drastically different from each other, and each has its pros and its cons. But as a whole, we're now down to just those 3 options, which is part of the reason why I think it's preferable to screen and identify the dogs earlier, because it potentially opens up a few more options, including we might have more efficacy with some of the non-surgical management options like the dietary restriction if we start it younger, before the osteoarthritis has really progressed.
So Sam, you've done tons of research about the chemistry related to arthritis. So whether it's a mechanical cause to begin with, or even primary arthritis where the chemistry itself is causing degeneration of the joints, what do you think we need to know about how to intervene in that process? What can we do about it?
That's a difficult question to answer because we don't have any treatments that we know can stop reliably osteoarthritis or the progression of OA once it occurs. It is probable that if we can begin treating individuals earlier in the course of the disease, that we can maintain their quality of life and potentially slow the progression of osteoarthritis, but we're not going to cure it. And then in terms of what treatments are those that could potentially mitigate the progression of OA or the manifestation of clinical signs. Again, this is an area where I think that there's debate, but usually I tell owners is the first 3 is optimal diet, optimal body weight, and optimal exercise regime. So similar things that would work well for human beings who have osteoarthritis, who are trying to optimize their mobility. Some of the diets that are joint-specific diets, I think there are some very good studies behind them. Imperfect, but very good studies that suggest that some of the joint-specific diets can be beneficial in either probably mitigating inflammation or at the very least optimizing apparent quality of life and comfort. And then beyond those, then thereafter come all the things about different injections or physical modalities, which warrant really detailed discussion. Certainly a substantial part of the research that I've done has involved looking at orthobiologic injections. So things like platelet-rich plasma, autologous protein solution, stromal vascular fraction, cultured stem cell therapy, and bone marrow aspirate concentrate. And I could find a number of people who could argue against proven efficacy of some of those. And again, it would have to be a long discussion, but I think that there is discussion to be had about whether or not those treatments are beneficial and could be used in patients with osteoarthritis. And I think in some patients, those treatments are worth trying. And I do so for some patients in my clinical practice. Intra-articular injections is certainly an area of interest of mine where I think that we can continue to try and explore and optimize those. They're used in humans, they're used in horses, they're used in dogs, they're available in all 3 species. And so it's one area to add to the repertoire of how to try and manage patients with osteoarthritis.
Yes, we do a number of regenerative medicine cases in my clinic as well. At what age do you feel, or at what stage of arthritis do you feel like those might be most helpful?
Well, most of the time when I'm seeing patients for whom I am using those, they're quite frankly individuals who have well-established osteoarthritis, unfortunately, who may not be surgical candidates or for whom the owners are electing non-surgical management, and therefore in whom we're trying a number of different treatments under the non-surgical management umbrella, of which the intra-articular injections are one option that we use. Intra-articular injections, and I say this in part for owners, they are not a prophylactic treatment. So I don't think that anybody should come away saying, all right, well, I want to prevent osteoarthritis in my dog. I'm going to start having their joints injected before we know that they have osteoarthritic change. Then an area of a little bit less certainty is whether or not the injections should be combined as a adjunctive protocol to patients who are having surgery. That's an area that's open for some more discussion. And I would say the answer to that probably also depends upon what the underlying medical condition is and what surgery is being done. But I think that there are potentially some surgeries and medical conditions where a series of injections following might be beneficial.
So I know you have a really busy referral practice. What are some of the common pitfalls that we might avoid as general practitioners before we refer pets to you?
Well, I think maybe I'll just answer this question this way. Some things that I find helpful to me, which I suspect might also be helpful to general practitioners, but that are not specific to a specialist, would be having owners provide video of their pet when their pet is showing whatever lameness or abnormal gait or behavior that the owner is talking about. Because certainly I think all of us have experienced a scenario where an owner will come in and say, my dog limps on its left front leg, and you're looking at the dog and you're like, I can't see that your dog's limping at all. And the physical exam is relatively unrewarding, but I can get a video from an owner that shows the dog clearly limping on the right front limb, or maybe it is limping on the left front limb. But the point being is that technology is so readily available in terms of obtaining video and sharing video that that's probably one of the easiest things to be done is say, before you send a case, before you make a decision on what you want to do diagnostically, if you're not confident as to whether or not the dog actually has a gait abnormality, ask the owners to provide that video information. And then from there, it makes it a little bit easier in terms of your physical exam, because you at least know what you're dealing with and where you need to hone in on your physical exam. Then typically you're following that with survey radiography.
Yes, I loved some of what you said. As a rehabilitation doctor, my primary goal, of course, is their function. So I don't get to do their surgery to change their bone fragments. My job is to help them use the rest of their body and to be able to get up and down, right? And so oftentimes as part of our intake, and we'll talk about this in one of our sessions, we have a form that we send home ahead of time to ask owners to bring pictures of their animal sitting, standing, and then a video of them getting up and down and going up and down the stairs. And I'll tell you, Sam, this has completely changed my practice. I can say that the most important video that I get, hands down, is actually one of them getting up and down from the floor. And maybe followed closely by going up and down the stairs. It has completely changed how I can triangulate where they hurt. So I love that you said that, because it makes a huge difference. And that's one of the places that we can really leverage our staff. We can ask our receptionists and our technicians to do that. In fact, when my owners haven't had time to make those videos, my technician will go in the room and make those videos and bring them to me before I see the dog. And 9 times out of 10, I can tell you where they're sore before I put my hands on them. I still have to do an exam. I still have to do all of my diagnostics, but it can be a really helpful tip.
The last thing I would add to that would be that the quality of the radiographs makes a big difference. And so if there's one thing that I would suggest, it is make sure that the images are of good quality. And that means both positioning as well as exposure. And so in turn, that means that for some dogs, they really need to be sedated in order to get those good images. And I understand that in a busy day, sometimes that doesn't fit well within the schedule. And I also understand that there are some owners who kind of push back against that. They have an unrealistic fear of sedation. And so one way I think that veterinarians could improve the quality of their practice would be to encourage owners to say, hey, it's important we get a bang for our buck when we get these radiographs. Your dog is not amenable to us getting good radiographs that are really going to help provide us answers, instead of us just getting some radiographs right now that aren't of great quality in a struggle. Maybe let's think about coming back tomorrow or in 2 days or whatever it is, and really be prepped and planned and really try and get the most out of this radiography experience. And then also be able to talk to the owners about, you don't need to be terribly worried about sedation, because that's the other thing, right? A lot of owners don't have any concept that there's a difference between anesthesia and sedation. So I think that taking the time to talk with owners about sedation in otherwise healthy dogs has a very high rate of success without complications, and can improve the value of the radiographs that you're going to the effort of getting. Could definitely improve the quality of one's practice, because you're going to get more information than when those radiographs get sent off. And we're at a day and age where most of the time those radiographs are getting sent off, right? And so if you get good radiographs and you send them off, you may find as the general practitioner that you're getting your answer just from the radiographs as they come back to you. And then it's easier to talk to the owner before you're referring it for another evaluation.
Agreed. Thank you for all you do, Dr. Franklin. I can attest to personal success with patients with Dr. Franklin for many years, and I'm so glad to have you here today.
Thank you very much. I've really enjoyed chatting with you. And again, I'm thankful to be a part of the summit. Look forward to the roundtable discussion.